Good afternoon and welcome to today's webinar, Making Sure Kids Are Healthy Enough to Learn, Innovations in Education Law and Policy, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on the network's website shortly after the conclusion of today's event. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. We will be addressing them during the Q&A session at the end of the event. Your moderator for today's webinar is Carrie Lowry. Carrie is the Deputy Director and Director of Grants and Research at the Network for Public Health Law's Eastern Region Office, where she provides legal technical assistance on a variety of health topics. Her current work focuses on empirical legal research and coding, injury prevention, and child and adolescent health policy. Carrie will be leading us through the rest of today's webinar, so Carrie, over to you.
Thank you, Charles, and good afternoon, everyone. Thank you for joining us on this webinar today. So I just wanted to give everyone some context for our speakers today, because on first glance it may seem that they're somewhat unrelated, but I assure you that they are. So research is showing us that education is a social determinant of health in its own right. Not only because education affords greater earning opportunity, but also because the cognitive development and critical reasoning skills that are learned in school affect health behaviors and decisions that are made about health across the lifespan. So despite federal laws that guarantee that all children receive a free and appropriate public education, major challenges exist for many students, from a basic lack of preventive care to hunger and adverse childhood experiences and trauma. So if education is a social determinant of health, and we believe that it is, then public health law should be engaged in finding solutions to ensure that kids are healthy and secure enough physically and emotionally to learn. So our speakers today will address 3 innovative school-based legal and policy strategies to improve educational and therefore health outcomes for children and adolescents. First, Dr. Erin will address the importance of access to school nursing services for student health outcomes, particularly in underserved communities, and legal strategies for improving access to these services. Dr. serves as Director of Research for the National Association of School Nurses, or NASN, where she promotes evidence-based school nursing practice. Dr. co-leads the development of a national uniform data set for school nurses and the identification of school nurse indicators. She co-led the creation of NASN's Framework for 21st Century School Nursing Practice. Prior to NASN, Dr. was faculty in the College of Nursing at Brigham Young University, and before that, she worked for the Utah Department of Health as the state and adolescent school nurse consultant. She also worked as a school nurse. Dr. currently sits on the World Health Organization's School Health Services Guideline Development Group and co-directs a global school nurse researcher consortium. She's certified as an advanced public health nurse and is a Robert Wood Johnson Foundation Executive Nurse Fellow alumni. Dr. is also a fellow in the National Academy of School Nurses and the American Academy of Nursing. She's passionate about addressing the needs of vulnerable populations and improving school-age children's health through research and data. So instead of introducing our speakers before they speak, I'm just going to introduce them all now so that I don't have to interrupt again. So after Dr. you'll hear from Professor Talia Gonzalez. Professor Gonzalez will address restorative justice and school discipline reform as a strategy for health equity. Professor Gonzalez is an associate professor at Occidental College in Political Science and senior visiting scholar at Georgetown University Law Center. At Georgetown Law, she leads the Center on Poverty and Inequalities National Research on Restorative Justice. She is currently the principal investigator of a 2-year project aimed at developing new policies and practices for school-based restorative approaches to better support girls' unique health and educational needs. Professor Gonzalez is a frequent expert speaker and advises and supports a number of projects and programs using restorative approaches in public systems and community-based settings. And finally, Matthew Swinburne will discuss laws that are designed to combat childhood food insecurity by addressing the school breakfast gap. Mr. Swinburne is the Associate Director of the Network for Public Health Law Eastern Region. Matthew's current work focuses on issues of food safety and security. He was a leadership scholar at the University of Maryland Francis King Carey School of Law, where he graduated Order of the Coif and magna cum laude in 2008. While at the law school, he worked as a judicial intern for the Honorable Richard S. Bernhardt of the Circuit Court of Howard County and as a summer associate for Venable. Matthew also participated in the law school's tobacco control clinic, advocating for state legislation regarding the tax rate of little cigars. And after law school, Matthew worked as a commercial litigation associate for Venable. After leaving the law firm, Matthew served as a law and policy analyst at the Center for Health and Homeland Security. At the center, Matthew worked on cybersecurity issues, emergency response resource gap analysis, and public health emergency response programs. Matthew was admitted to practice law in the state of Maryland. So without further ado, we would like to pass the baton to our first speaker, Dr. Erin Mon. Erin?
Great. Thank you so much, Carrie. And thank you for this opportunity to share a little bit about school nurses' role in addressing social determinants, and particularly those students who are most vulnerable. As the non-lawyer in the group, I'm also very excited to hear everyone else's discussion and the topics of today. So let me go to our next slide. What I'm going to talk about, as Carrie mentioned, is the school nurse workload across the United States, because that plays a big factor in what school nurses can do, and I think it will provide some context. After that, I'm going to talk about school nurses' role in the 21st century, addressing both individual student social needs as well as population-level social determinants of health, and particularly in underserved areas. So as was mentioned, education is really important, and it's been found to be a social determinant that we oftentimes think of as an adult that someone needs education. But in the role of schools, it's also making sure that students get a proper education when they are able and that they stay in school. And as many of you probably know, since we're talking about social determinants, it's oftentimes many factors that influence if a student is able to learn. It's, of course, their ability to learn, but it also so much has to do with the social context around them that makes it if they're able or prepared to learn or to concentrate. And oftentimes there are many health-related issues that are impacted by social determinants and social needs that impact if a student is really able to learn. And that's where I come in with the school nurses, because it's oftentimes school nurses are one of many in a school setting as part of a school health team that can address some of these needs to make it so students are able to be in the classroom and able to learn what they need to learn. So we make them so that they're prepared to be there. But just to give you context first, so in the United States, there are, as you can see here on here, about 95,800 nurses. This includes licensed practical nurses, which is usually a 1 or 2 year degree. It's oftentimes a vocational degree. Sometimes they're called licensed vocational nurses. Registered nurses, which is the far majority of school nurses. And at our association, the National Association of School Nurses, we recommend that it's a baccalaureate prepared registered nurse who is in the schools because of the training that they have. Although in some schools there are also nurse practitioners, advanced practice nurses who work in clinics or like a school-based health center or in a clinic as in a health office. So you might wonder, well, how does this look across the United States? So let me tell you. Here it is split up between private schools versus public schools. As you can see, there's a lot more public schools that have a full or a part-time school nurse compared to a private school. So, and then you can also see that it's elementary schools that have a larger percentage of school nurses that are in the schools compared to secondary or a mixed school. Across the region, I personally find this slide kind of amazing to see how different it really is. Now granted, it's only split up into 4 regions of the United States, but looking on the right-hand side of your screen with the New England and the northeastern states, I should say, those schools, 80% have a full-time school nurse, and only a little over 5% do not have a school nurse at all. So most of the schools are covered. Now, this is not to say that it's okay that there's 5% that don't, or close to 6, I guess, that don't have a school nurse. Of course, we would like a school nurse in every school. But statistically, the far majority do have a school nurse. And then if we go to the south, we can see 72.9, so almost 73% of school nurses, or I'm sorry, of schools have a full-time school nurse, more part-time, and there is a 14% that don't have a nurse at all. If we continue across and go up now to the, I guess it would be in the middle, in the lighter, not in that kind of color green, where Midwest, 57 almost % of schools have a school nurse, but you can see there's more part-time and more schools that don't have a nurse at all. And then you come to the far west, and as Carrie mentioned, this is where I practice school nursing. I actually am from New England, so I was used to a school nurse in every school, but I practice school nursing in Utah, where it's actually, well, almost split, a little bit more, almost 40% do have a school nurse, but 30%, and that's not a typo, it's 31.1% have part-time school nurses, and then 31.1% have no school nurses at all. So we're going to talk about this. This alone is the disparity of access to care, but it also impacts greatly how much a school nurse can do in addressing the social determinants of the students. This is just a slide that kind of looks at it. You might have been wondering, so how does that work? And so in many cases, when even with a full-time school nurse is covering multiple schools. And highlighted in the red, you can see in the Northeast, again, most of them cover just one school, so they're full-time in the schools. In the South, it's still over half that are in just one school. As you go to the Midwest, it's only 37%, and then if you go to the West, only close to 21% cover one school. Well over half actually are covering more schools, and that was my case. I covered multiple schools when I was a school nurse. So this again also makes it difficult to really be able to address social needs, and particularly those are the most vulnerable, because the workload is oftentimes not split up by the schools that have the most need. It's oftentimes, it should be, and we're working to get more of those to do that, but oftentimes it might just be split up by number of students or number of schools and just equally divided. But in doing so, we lose the ability to really address some of the complex needs that are found in our most vulnerable populations. And in fact, this is I just wanted to share, this is a study done by the Centers for Disease Control and Prevention. There is a study, a survey that used to be done regularly. Sadly, it isn't anymore due to funding, but it's called the SCHIP study, which looks at school health policies and practices. And they took the data and they did an analysis of the data to find out of schools that had a school nurse or that had a provider, like a healthcare provider that was also on call usually, how many of the schools also were providing services, and there's 4 services in particular that they felt were needed for chronic health management. Now, I realize chronic health management isn't necessarily always social determinants of health, but there are often comorbidities that influence chronic conditions that are social determinants. And as you can see, only a little over half the schools, 57% in that last part of the table, actually provided all 4 services. And they found that when there was a nurse, it was much more likely for those services to be covered, and also as well if there was a provider that provided consultation. So showing again that when there is a school nurse, more things can be addressed. At NASN, we have this framework for the 21st century school nurse, and this just shows that oftentimes you might think of the school nurse more of doing care coordination, that top yellow area, which is where we would think of like chronic conditions. But we really see the school nurse as well-rounded in addressing many things. Leadership, quality improvement is like our data and using data to better understand and track information. And also we're working on, we hope to develop better tools to actually better and earlier identify students that are at risk and that have social needs before it becomes obvious, that we get them earlier on in the process so that we can address them better. I really feel that the school nurse is the kind of the front line of public health, and since they're working with the students and their families and they know where the children live because of the school that they're at, oftentimes things could be identified quicker if we had the right tools in place, and that's what we're working on. And then community public health comes into play with working with a lot of these social concerns, because as we look at it different, this would be a very large classroom, but thinking if per 100 students, these show you some of the social needs that students face. Hunger is a big one, and I know that's going to be talked about later. But that English is not the first language spoken at home is also quite great, as well as coming from a single-parent family, as well as some of these other ones, the transportation, housing, lack of health care. All of these are things that students face, and when they face them, some of them are very resilient and it doesn't impact them, but many of these greatly impact their ability to learn. And so that's where the school nurse comes in. And the school nurse, here's a few areas where and how school nurses can address the individual social needs of students. First of all, we know that there are health disparities. So being able to identify and know where there's already inequities and addressing those first and foremost is really important. Chronic absenteeism is coming on the forefront more. And this is important because actually we have a project going on right now that's funded through a CDC contract, Centers for Disease Control and Prevention. And it's looking at just chronic absenteeism due to healthcare reasons. But our nurses that are participating in the project right now are finding that it's usually social and family context that is a bigger issue than maybe the actual health need. And there's concerns that just need to be addressed that the school nurse can help. So that is as a way of actually identifying students in a manner of some social needs that might not be as evident. Sometimes it's more evident, but if not, then looking at those students who are chronically absent, which is 10% or more of the school year, which actually translates to only like 2 or 3 days a month. And if you look at that, and especially if you start, like we're at the beginning of school, at the end of September, it's the beginning of the school year. Usually kids are pretty good at staying in school. If they're already missing that many school days, it's a red flag, and school nurses, as well as many others, can use that as a beginning point to identify what's going on that's making it difficult for the students to be in school. Because we also know if they're chronically absent, they're more likely to have problems with school and they might drop out, which again goes back to our topic today of the disparity of not having, or not disparity, I'm sorry, the social need and the social determinant regarding education. Some of the other social needs that school nurses address that probably are more linked with specifically with health are related to access to medical care. So dental care is actually a huge issue. Many students might have health insurance, and there's many great state programs, but dental is still a huge issue that is not covered oftentimes by an insurance. And with children, if they aren't getting regular checkups, by the time we identify concerns and cavities, they might be to the extent that general anesthesia is needed, which of course increases the cost greatly, which makes it more difficult for families to get the care that they need. So trying to identify issues early, but also trying to identify community resources that will address dental needs is huge. Vision is another one. It's pretty common vision screening done in schools, but it's, again, another area that oftentimes health insurance doesn't cover. And yet, if a child can't see, how can they learn? And then finally, of course, the physical needs and mental needs as well. All of those, sometimes there's a need for getting into access, and school nurses can help students get into the care that they need so that, again, they can, with the idea that they can come back into school ready to learn and focusing on learning. At the same time, school nurses also work with community resources to help if food banks are needed, getting them into a food bank. I mean, if they can't afford prescriptions for medications, this oftentimes happens, especially if it's a routine medication oftentimes, or it's not that it can't be afforded, but because of family situations, it might be hard to actually go pick up the prescription. And so there's actually programs in schools with parent permission that make arrangements to get the prescriptions. I'm thinking of asthma inhalers in particular, to make sure that they're in school so that if the student has an exacerbation, it's treated quickly, as well as just routine maintenance as well. The other area that oftentimes might be an issue is they might have a healthcare provider to go to, or you give them the resources to get to a food bank or somewhere else, but they don't have a car, or they can't afford public transportation. And so school nurses have a lot of resources that people might not realize that can help families get to the resources they need to address those social needs individually from the individual students. In addition to that, though, this is one of my favorite slides. So as was mentioned, I'm a public health nurse by trade, and I love this. This is a pyramid done by the Centers for Disease Control and Prevention that shows what interventions provide the largest health impact. And you can see at the top, which is the smallest impact to an entire population. That's where counseling and education is done. It's very important. It's not saying not to do that. But if you go farther down on the pyramid to the largest and lowest level, socioeconomic factors. And this is actually addressing poverty. This is actually addressing access to education, to housing, and inequities. And so where before, and school nurses do a lot with addressing individual social needs of students, we don't really get to addressing social determinants of health until we get to that population infrastructure level. And that's really important in this discussion is we need to help individual students from the day-to-day, but it's also a responsibility, and I think this is where laws and changes in infrastructure can really make a difference in really addressing the large population social determinants of health. These are a few ideas that I came up with where school nurses can help with this as well. First of all, advocating for community structure changes. And this is not just the role of the school nurse. I'm just sharing perspective of what I do and the people that I work with. But it's actually a team effort of making sure there's structure in place to address housing issues. There's so many links. In fact, I just read an article this morning about impact of air pollution and mental health and anxiety, I believe it was, with students. But we're learning more and more about how environment actually does impact students' health. And it's not just environment, but it's environment in where people live in their housing are greatly impacted. The stress at home due to maybe that, I don't know, whatever it could be with poverty or jobs or working multiple jobs, all of those social determinants of health impact the student's ability to concentrate and learn and be able to come to school. And so we need to address those at that community level. It's a great opportunity right now, a window of opportunity really, with school education and health reform issues going on with reimbursement in particular and how to address health in that more holistic approach. So right now about 82% of school nurses are actually funded by education. When school nursing started back in the early 1900s, it was actually part of public health, and then it kind of has moved over and become the financial responsibility of education. But as we're looking at reform, both in what is the role of education, which is oftentimes more than just reading, writing, and arithmetic and anything else, which are very important, but now that we understand more about social and emotional learning and all those needs of a student, what is school really need to be? And in addition, we're looking at healthcare reform and the value of various health professionals and how does that impact outcomes and how is that funded. So I think those are some other areas that we can also address, making sure that we have the right support system for students so that they can learn and get the education they need. So actually, laws regarding access to school nurses would actually help, as well as others. I don't want it to be egocentric, only school nurses, but others as well. And addressing payment. Some schools do have a reimbursement way for Medicaid for some of the services they provide. Not all districts have the capability of doing that, mostly because it's a lot of paperwork, and it's larger districts are the ones that have the capacity to do it. There's also been studies regarding the return on investment, and so this brings up, there are also other ways that you can finance school nurses. Health departments still do. hospital systems are actually finding that when they employ school nurses, it actually helps not just have access to the, not have access, wrong word, and not address the health of the children so that they don't end up in the hospital, but also have access to the families. Because again, it's the family unit that oftentimes there are many issues related, social issues that are impacted by that. So looking at that, how can we look differently at how do we fund population health and school nursing so that those frontline nurses and others are able to identify students who are at risk as well as those with the social needs early. And then the other area is for access to school nursing, and also in relation to other rules and laws in schools, is there's not really a lot of laws. A lot of it is local control. It's the way our Constitution was set up, actually. Both health and education is at the state or even district. A lot of choices are made that way. But there are some laws. And in fact, in Delaware, there is a law that requires a school nurse baccalaureate prepared in every unit, they call it. There are a few other laws, but the issue is that there's a law, but there's not the teeth to back it. So if a district doesn't follow the law, the fine might be very small. That's true in Pennsylvania. And so districts are willing to pay the fine versus getting the access to the school nurse that's needed. So looking not only just at laws, but also policies and standards regarding school health services to better identify what's going to help make sure that there's the access to the professionals needed to make it for students to stay in school. That's the important thing. And then also not just the law, but the financial backing of it. Because right now, as I mentioned, a lot of the burden is put on the schools, and it's expensive for them. And there's a lot of issues. So I always like to end with a quote. So here is my quote for ponderance. An ounce of prevention is worth a pound of cure. And so as we're looking with students, it's about social determinants of health and education. And about many other issues as well that will impact their lives. And if we put the funding and the support needed using laws and other infrastructure, we also will save in the end. So that's my presentation. I just have the references here because I'm a researcher, so I've got to show them there. And so now I'm going to turn the time over to Talia, who's going to talk about restorative justice practices.
Okay, great. So very briefly, I just want us to be thinking about how a more narrow view of school discipline reform and how a more narrow view of the use of one form of non-alternative or non-exclusionary discipline or restorative justice is actually more than that as an antidote to discipline, but really thinking about this in the context of health, both as a remedy to exclusionary school discipline, which has a whole set of negative outcomes that manifest in young people both in the immediate but also in the long term in terms of their health, and then also how we can think about these laws and policies that exist all the way from the state level, states that have passed laws that have codified the use of restorative justice and simultaneously decrease reliance on exclusionary school discipline, how those laws all the way down to the actual practices in schools and even the codification into codes of conduct or discipline code policies are actually advancing health justice and should be understood through a health equity lens so that it's no longer just a conversation that lives within more of a civil rights context, because there's really been a missed opportunity to understand education as a social determinant of health and the relative impacts that happen when we start to use forms of exclusionary discipline. So the first slide here is really just a repetition, I think, probably in some ways of other things that we have thought about, which is the social deterrence of health. And I just want to remind folks that in this conversation, but more broadly, as we think about the social determinants of health, there is an interrelationship. So while I'm focusing on education as a key social determinant of health in creating and laying a healthy foundation for lifelong achievement, that's across a whole set of indicators. So for example, it's been validated to show that by age 25, individuals with a high school degree can expect to live 11 to 15 years longer than those who did not. So we're not just talking about education as access and attainment within the moment, but we're thinking about education as the totality of a life experience that also then has strong correlations to employment, so thinking about economic stability as a social determinant of health, access to housing, entry into formal punitive systems, thinking about the juvenile or criminal justice system. So to be cognizant of the fact that when we're framing or considering education as a social determinant of health and the relative ways in which exclusionary school discipline really mitigates those possibilities, that we are also talking about the impact on other social determinants of health. So I am advancing what my colleagues most recently have suggested as a health justice framework. And so it's really understanding the work that many of us are doing, not just as a matter of civil rights or not just a matter of a particular justice strategy, but really as that opportunity to both strengthen but advance health, public health advocacy in particular. So how and where do we understand the use of a particular intervention or set of practices in schools, and then the outcomes that those have for individuals both in the short and the long term, but how and where has policy change should really being understood as public health policy. And it really allows a different set of attentions, whether that be at the research level all the way down to then policy framework. So then how are we considering the use of restorative justice within a larger multi-system and multi-tiered structure of support for young people so that schools really are the sites of health and well-being and that they play an essential role in ending health inequities. So what role do schools play? First and foremost, education as a key social determinant of health, but then secondly, really exists around the space of exclusionary school discipline as its relationship to toxic stress and adverse childhood experiences. So the first thing that I would ask us all to be mindful of is the fact that there is a strong correlation between the number of suspensions and expulsions that a student experiences and ultimately academic disengagement or dropout, and that's the same population, as we'll get to in a few slides, that are experiencing toxic stress and high levels of ACEs or adverse child experiences. So the dose effect of ACEs of having an increased number of 1 to 10 of adverse childhood experiences is a similar mirroring in a population, in particularly students of color and students with disabilities who are likewise experiencing exclusionary school discipline. So there's really an opportunity for schools to start to mitigate or arguably exacerbate if they're going down the pathway of continuing to use punitive discipline and exclusionary school discipline practices relative to the effects of toxic stress and ACEs. And so why then should we absolutely think about this as a health issue? Because we're not just thinking about the deprivation of access to educational opportunities in the classroom in the moment, but we're really talking about how and where we're teaching young people those key social and emotional skills that have a long-term impact on their life, and how and where those social emotional skills or feelings of relationship and connectedness are putting them at greater risk, not just for health insecurity and health inequity, but social and economic instability. So for example, it's been a study last year of multiple schools in Minnesota found that the use of exclusionary school discipline wasn't just disrupting student learning, but it was promoting feelings of being unvalued and unwelcome, and that really was not addressing then both the root causes of a particular behavior that a young person might be manifesting, but that it was absolutely breaking a connection and a key protective factor that the CDC has defined of school connectedness that help children and adolescents avoid multiple behaviors that put them at risk for adverse health and educational outcomes. So there's really sort of a duality of pushing young people both out of the classroom and how and where that's impacting their overall achievement and educational status, in and of itself a health issue and the long-term health impacts, but then also what it's doing to really break down the key protective factors that we want schools to be able to support young people with. So a quick snapshot of the data so that you really understand the magnitude of which what we're talking about here around exclusionary school discipline. For those of you that work in the space of looking at discipline data, and particular data that comes out of the Federal Civil Rights Office or the Civil Rights Data Collection or the Department of Education, you know that we're always a few years behind in terms of reporting, so that's why you're seeing what feels like slightly older data, though it is still relevant today, as we saw with last year's Government Office of Accountability report, or the GAO report, which I'll turn to in a second. So 2.7 million students experienced at least one out-of-school suspension. You see the disaggregation and the distribution across different identities and categories. Obviously, we see in particular representation relative to race and to gender and how and where that's impacting young people. Here we're now thinking from suspension, so the removal for a short determinate or indeterminate amount of time to complete social exclusion and removal from the school community, expulsions. So thinking about a disaggregation relative to race and gender as well, we're seeing that disproportionality become apparently clear, which has been one of the key drivers relative to thinking about why this is a civil rights issue, and I think has really masked that this is a health issue as well, because these are the same, in many instances, young people who are experiencing hiatus, or because the punitive discipline is something that's come into their life, it's compounding pre-existing health inequities. So, for example, students of color, LGBTQ+ youth, or students with disabilities already have higher rates of toxic stress, and removing them from the classroom is breaking key and core foundations. The GAO report, or the Government Accountability Office report that came out last year, looking at students with disabilities and the representation in receiving disciplinary actions and how and where that's distributing. There's some keynotes at the bottom that I put there just so that we can have some highlights to take away. We see it relative to peers without disabilities, but we also see within there a disaggregation that among students with disabilities, Black students were overrepresented. So now that intersection between race and ability. Then often I get asked the question, and so I like to be able to provide this data, well, it's the type of school, right? That there's particular schools that are using exclusionary school discipline in particular ways relative to race or to gender. And the GAO report really helps unmask that a little bit, that regardless of the type of public school, you are still seeing that disproportionality relative to different rates and peers. If we step back and we think about this now in terms of the pre-K level, because I want to make sure that we're also reminding ourselves the importance of what early childhood education is, but also how and where the foundation that we set for young people at the very beginning is essential for their positive health outcomes. These are the trends at the pre-K level. So, you know, in terms of suspensions and expulsions, it's something that's happening on a regular basis. If you look at the last sub-bullet point there from 2017, tracking of data that 250 preschool students are being suspended or expelled on an average school day, I think should be terribly alarming for individuals, not just in terms of thinking about disproportionality relative to race or gender or LGBTQ status or disability, but because what this is doing to really disrupt the totality of a young person's ability to function within school, but also that it restructures the ways in which they're able to engage with the material. So I hope, right, in some ways that this is the logical place to sort of pause and say exclusionary discipline and the particular sets of practices of suspensions and expulsions that we saw grow out of the 1980s and really exist right now is something that we have to pay attention to as a health equity issue. And we'll break it down into thinking about across these 4 different dimensions, in particular that it's not just isolated to a single moment, but beyond. So in terms of thinking about exclusionary school discipline and academic outcomes, also a researcher, happy to share a whole literature review or set of sources for individuals. To hit the highlights, decreased academic engagement, decreased performance in the classroom, impact in terms of likelihood to drop out. So, for example, a longitudinal analysis of more than 1 million children in Texas indicated that a student who received a suspension or expulsion was more likely to drop out or be retained in the same grade than their peers, and that there's a dose effect, too, with exclusionary school discipline that we see manifested with ACEs as well, and the ACLU has studied this and reported this in numerous policy briefings and with collaborative researchers, that your risk of subsequent suspensions and expulsions increases every single time that you experience one, and that it also likewise increases your likelihood of dropout. So if we come back to that one of the first data points I shared with everyone in the context of health, is that by age 25, if you have achieved a high school degree and you can expect to live 11 to 15 years longer, but yet you're a young person who's been experiencing or experienced a single experience of exclusionary discipline, your increased likelihood of dropping out means that you're seeing potentially a decrease in what your life expectancy looked like. Relative to the classroom, right, it's not just thinking about outside of the classroom or educational experiences. Again, risks of future disciplinary actions, decreased feelings of safety, coming back to multiple studies that have been done about students' disengagement, feelings that are putting them at risk or disconnecting from the classroom. And the last one in particular is lower school connectivity. And I'll come back to that, though I've mentioned it already once, is that the CDC ranks school connectedness as the 2nd highest protective factor following familial connection or parental connection, defined in those terms, for scaffolding youth and adolescents in particular against high-risk health behaviors. So let's follow that train of thought through. A young person experiences exclusionary school discipline, decreased sense of school connectivity, increased risk, potential risk for engaging in high-risk health behaviors that have both short and long-term negative impacts. Again, recognizing that this isn't just about education as a social determinant of health. This is in relationship to other social determinants of health. So we see a doubling in the poverty rate for those 25 and older without a high school degree. We know that there is a strong correlation of entry into the juvenile and ultimately criminal justice system, most often referred to as the school-to-prison pipeline. There's been a tremendous amount of research and advocacy in thinking about these larger collateral consequences. And then, I think 2 really key and important areas, especially for young folks and students that have experienced ACEs and are experiencing them at higher rates, that schools that are utilizing exclusionary school disciplines with these marginalized populations are compounding the effects of stress, deepening feelings of fear, isolation, and mistrust of adults. So you have this widening gap, this increased impact and outcomes of exclusionary school discipline that's not just isolated to exclusionary school discipline as having a health outcome, but how and where it's then coming into play in relationship with the same population of individuals. It also means that from an intervention standpoint, the use of exclusionary discipline is not actually addressing the root causes of many forms of behavior, and that it is, again, coming back to one of the most important protective factors, decreasing school connectedness, which leads to a whole host of negative outcomes. So how does this all fit together? If someone asks you in an elevator or some other wonderful space in which you're occupying with them, what did you learn today? And how does school discipline and health justice fit together? That's what I'm hoping we can do right now. So at the end of the day, schools really should function as sites that are safe, that are nurturing, and are learning environments first and foremost. And so there's this really amazing opportunity to think about how schools can provide that essential foundation for positive health outcomes, and that we need to move away from practices that are currently exacerbating disparities, but then more importantly, in doing that, simultaneously increase the use of practices that can help achieve goals like school connectedness, resilience, self-efficacy, and really scaffold young people with the core social emotional capacities that really perpetuate what I would say is the foundation. It doesn't just perpetuate, but it's the foundation of a healthy life, but really sets them up with the scaffolding necessary to achieve that. So 3 key protective factors that come out of schools, but more importantly, a whole host of those academic settings, so in the classroom, in the hallways, on the playground, all of the places that we knew young people move, with school nurses, with paraprofessionals, with social workers, with principals, sort of every human being that exists within that school community. First is positive academic experiences and what that means relative to increasing those opportunities and really pushing and supporting the academic and intellectual growth, the school connectedness as supportive relationships, and the core social and emotional capacities. And so to bring us to the definition that the CDC and others have hit on relative to school connectedness, it is that extent to which students in particular, young people in particular, feel personally accepted and respected. And what does that mean then as we think about health? That means that there's 2 main ways that this is impacting the ultimate health of young people. First is improvement of health behaviors that we often see associated with traumatic symptoms. So that can be emotional distress, that can be suicidal ideation of behavior or substance abuse or weapon-related violence or even early sexual activity. But the second is increased self-efficacy and resilience and how that relates to academic achievement. So by facilitating school connectedness, we see then a linkage to overall educational attainment, and as a result, improved health outcomes. So for example, students who report higher levels of school connectedness, multiple studies have validated they're less likely to leave school, accrue absences, or engage in behaviors reflecting decreased self-regulation. So again, it's that foundation for lifelong health. So myself and others have looked across different practices, but also tried to come up with sort of core principles or draw on the core principles of others. And the Center on the Developing Child at Harvard University identified, and I think many of us would agree, being those that move in the wheelhouse of both health and schools, that these are 3 principles that can help outcomes for families and children. So supporting responsive relationships, strengthening core life skills, and reducing sources of stress. And so let's think about those now specific to restorative justice, because at the beginning of this conversation, there was a slide that had restorative justice in it, but yet I have readily been absent in discussing restorative justice. So I want to take these 3 principles in particular and map what we know as some, but not the exclusive universe of restorative justice relative to those. The reason that I'm discussing restorative justice is not simply just because I've spent more than the last decade looking at this in schools, but it is restorative justice and social emotional learning in particular as a form of intervention in a school really is the most dominant at this point. And if you're looking specifically at exclusionary school discipline, it is restorative justice as opposed to social emotional learning. And in fact, when you map the 2 against each other, social emotional learning or the CASTLE framework and restorative justice as principles, practices, and interventions at the whole school framework, many of the outcomes are very similar. But in the context of exclusionary school discipline, restorative justice really has moved into a dominant form. There are presently 16 states that have passed restorative justice laws specific to the education context, with some states with multiple laws. So for example, in California, there has actually been the codification of restorative justice relative to exclusionary school discipline 12 times. I just checked with my students on Tuesday. And so the multiplicity of uses comes through, and it's not just centered on the coast. For example, in Indiana, there's 2 pieces of legislation, one in 2015 and one in 2018. And the first one actually mapped specifically in thinking about social emotional learning and the core capacities that can be improved. So the whole school model of restorative justice ultimately looks at 3 tiers by which we support young people in their growth within a school community. So you have building and strengthening relationships all the way up to supporting reentry or the most intensive forms of support, and that also then is in relationship with a whole host of other mental health and health professionals that work inside and outside of schools. So very quickly, just because I know we're at getting close to time and I want to yield the floor to my colleague. First design principle, building supportive and responsive relationships. I've included a couple different studies here very recently from 15, 16, 17, where school connectedness, resilience, self-efficacy, and engagement are at the core of them. These studies exist at both the high school level, at the K through 3 level, and then the pre-K through 5th grade level, and you can see the bolded areas yourselves. And then in thinking about the second design principle that really helps support the health and well-being of children and families, how do we strengthen core skills? If we're no longer relying on exclusionary school discipline, which breaks down core life skills, what do we use as practices instead, or what is the multi-tiered system support that we do? And that's, again, thinking about 2 examples in particular, how that's occurring. I had the pleasure of working at a school for 7 years and developing a case study over the whole host of a whole school outcome, where we found self-advocacy, conflict resolution, and leadership development. There was a 2-year ethnographic study in an urban public high school that was specific to the use of restorative practices with young women. And so now thinking also about how gender plays into this, and promoting refined anger management, active listening, and a host of proactive skills. And then lastly, reducing sources of stress, suspensions and expulsions and social exclusion, and the breaking of relationships between peers and teachers is a source of stress and can exacerbate pre-existing forms of stress. And so this is the most commonly cited information, is that restorative justice has been used in a manner to ultimately address exclusionary school discipline, so decrease in suspensions and expulsions, decreases in truancy, impacts on the suspension gap or disproportionality. So really looking ahead, I think that from a policy standpoint and from a legal standpoint, where we should be paying our most attention, one is to really re-narrate, right? So again, I entered into this conversation saying that we can't just think of restorative justice or the shifting away from exclusionary school discipline or punitive discipline practices as an antidote to simply discipline, that it's also about health. So increased state level legislation and advocacy, continued shifting away from at the local level, because so much, to echo my colleagues previously, is in local control, removing the possibility for exclusionary and punitive disciplines except for in instances of safety and where law mandates it, and developing increased whole school models. So I yield the floor, and I apologize that technology was not working as smoothly despite all of our best efforts at the beginning.
Good afternoon. I am Matt Swinburne, the Associate Director here at the Network for Public Health Law's Eastern Region, and I'm going to talk today about the breakfast gap, which is the huge discrepancy in the children that participate in the National School Lunch Program as compared to the school breakfast program. And what I'm hoping to cover today is why this gap exists and the missed opportunity that it represents in terms of public health. And so looking at the public health implications of this gap, as well as covering some of the research that the network has done this spring, looking at state legal interventions that are focused at increasing student participation in the school breakfast program, because here in the United States, we have over 12 million children who suffer from food insecurity, and this has a broad range of public health as well as educational effects. But before we get into that material, I just want to provide a little bit of background in terms of the nutrition programs we're going to be focusing on. So the National School Lunch and the School Breakfast programs are nutrition programs that are a partnership between the U.S. Department of Agriculture and state and local governments. Federal law doesn't mandate that schools participate in this program, and it is a voluntary program from a federal perspective. And the way it functions is the USDA provides reimbursements for the school meals that are served at participating schools. And the reimbursement that schools receive is dependent on the type of meal, lunch versus breakfast, as well as the needs of the students who are receiving the meals. So the greater the financial need of the child, the higher the reimbursement that the schools receive for their meals. For example, within the federal program, free meals are available to children whose families are below 130% of the federal poverty line. And so when a school serves a free lunch, the federal government reimburses them $3.41, or when they serve a free breakfast, they're reimbursed $1.84. As you know, the other two categories of meal are the reduced price meal for children who come from families between 130 and 185%, and then above 185% is the full price meal. But there's reimbursement for each meal regardless of the economic status of their family. Just the amount of reimbursement received by the school is different. Now, in addition to this kind of individual need analysis, there's a categorical eligibility for students. So some students who are receiving benefits like SNAP or TAMF, and that acronym the next acronym may be a little less familiar, but that's the Food Distribution Program on Indian reservations, are automatically eligible for free meals. Now, in addition to student eligibility, entire schools can qualify for specific types of a delivery model. So that if the term that's used is the community eligibility provision, allows schools that offer whose population, and my slide isn't visible to me right now. I apologize. Technical difficulty, but the community eligibility provision looks at allowing schools to offer free meals to their students when those schools service particularly needy children, looking at the number of students who are eligible for that categorical eligibility. So that's a little bit of background I think will be helpful once we start to look at the state interventions that look at addressing this breakfast gap. But why do we, what is the magnitude of this gap? And I think this is really important to see kind of the missed opportunity we have here. So you have more schools providing lunch than provide breakfast, but where I think you see the real difference is the number of meals that are served within each of these programs each day, with nearly 30 million children receiving lunch through the school lunch program versus only under 15 million receiving breakfast. Now, a lot of these children who are missing out on this opportunity are children who are food insecure. So how do we address this kind of huge gap between these two programs in terms of involvement? Because I think we're missing children who could benefit from these programs. And when this problem is looked at, it really comes down to kind of three types of barriers. And simply put, you're looking at some logistical barriers, some social barriers, and some economic barriers. So from a logistics standpoint, not every school offers a school breakfast, so students are unable to participate. And there's also kind of a more practical challenge, and when school breakfast is offered, traditionally it is offered before school starts. So there's the challenge of getting students to school in time to take advantage of the program. So these are just some examples of the logistical challenges. And with children, there's also kind of a social barrier in young people being very conscious of their peers and how they're perceived by their peers, and students not wanting to stand out as the child who's having breakfast before school and being perceived as different. So there's some social kind of barriers that contribute to this breakfast gap, as well as some of the challenges that are economic, whether it's the cost to the schools in providing the breakfast program or the economic barriers for the students in terms of participating. So even though there are students who qualify for free meals, there are students who qualify for the reduced price meals, where they have essentially up to a 30-cent copay for that meal, and even that 30-cent cost of the breakfast can be an economic challenge for them and their family. So here's just some of the factors that contribute to this huge discrepancy between the students' participation in these two nutrition programs. Now, we're looking at this from a public health perspective, and food insecurity has a broad spectrum of negative health effects on children. It's linked to childhood obesity, cardiovascular disease, asthma, diabetes, poor mental health. But in the context of this webinar, I think it's important to focus on the impacts of hunger on a child's academic performance. So if we're looking at education as a determinant of health, how do we ensure success in this area? And hungry children can't perform up to their potential in school. And so there have been studies that look at the impacts of students' participation in breakfast programs, and they show that students who have breakfast score higher on standardized testing, have fewer behavioral problems in school, fewer trips to the nurse, stronger attendance, and higher graduation rates. And there is an excellent nonprofit that works on child hunger called No Kid Hungry, and they've conducted some studies to try to quantify the effects of providing school breakfast and addressing this breakfast gap. And they found in one of their studies, they estimated that a 20% increase in school breakfast participation across the country could have these really tremendous kind of academic impacts in terms of 3.2 million students achieving better standardized test scores, almost 5 million fewer absences each year, hundreds of thousands more students graduating from high school if we can help address some of these nutritional needs and kind of the issue of food insecurity with these students by kind of maximizing the potential of the school breakfast program. So with that kind of context, what the network did this spring is I worked with two of our student attorneys here in the Eastern office on a project to look at what state policies are being utilized to try to encourage schools to participate in the breakfast program, as well as to encourage students to take advantage of this. And Kasia and Kirby did an amazing job in their research and developed two really great resources that are available on the network's website. One is an issue brief that talks through this research in much greater detail than I can today. And the other is a 50-state survey that looks at each jurisdiction kind of in a side-by-side comparison based on three categories of policy intervention. And we'll look at these six categories of policy intervention, and we'll look at these policy interventions in just a moment. But I want to highlight that if you're interested in student nutrition and this issue, the network has these two great resources available on our website. But moving forward, realizing we've got a little bit of time left, I'll start looking at these policy interventions and kind of how within these policy interventions states take differing approaches. So the first is fairly straightforward. At first glance is, there's no federal mandate that schools participate in either of these nutrition programs, but 29 states and D.C. have created mandates that say their schools have to offer breakfast, which is, I think, a great policy, but there has to be a closer look at each of these policies because there are thresholds that exist. So schools don't have to participate in many jurisdictions unless they meet a need threshold. So that the student population they serve has a particular need for these nutrition services, and they generally measure that by looking at the percent of enrolled students who are eligible for free or reduced meals. So that threshold can vary from state to state. You have some thresholds, like in Texas, that are fairly low at 10% of the student body being eligible for free or reduced price meals. And then there's states like Connecticut, where the threshold is much higher. In addition to these thresholds, there are exemptions and waivers that schools and school districts can seek, based on financial difficulty or what's seen as low participation in these programs. So this is one of the first policy interventions the students looked at. And if you're interested in seeing if your specific state has adopted this type of policy, it's all available on that 50-state survey. The next innovation we'll look at, or policy approach we'll look at, is requiring an innovative breakfast model. So kind of moving away from the traditional before school, in the cafeteria model that creates some logistical and social barriers. 10 states require schools to provide breakfast through an innovative program. And innovative programs are often fall in the category of breakfast after the bell, so that rather than before school, students can have breakfast during the school day, whether it's breakfast in the classroom for younger children. Often in high schools, you will see an option where students can grab their breakfast from a food cart in the hallway, but there are these 10 states that place this innovative breakfast model requirement on schools. But again, there's often a threshold of need to activate the requirement. So, for example, in New York, 70% of the enrolled students at a school have to be eligible for free or reduced price lunch before this mandate kicks in. And again, there are waivers and exemptions to this, but it's one of the policy interventions that I think is quite promising. Now, one of the barriers that we identified earlier was that there is an economic barrier for schools at times for creating new breakfast programs or growing their breakfast programs. So you have 11 states that have identified additional funds to help cover those startup costs or expansion costs. For example, I mentioned these kind of breakfast carts in the hallway, did a little internet research, and this model right here goes for $2,300. So, states are trying to cover these equipment costs as well as additional staff time. These funds can come through grants that, require applications or state appropriations. And again, kind of there is a priority system, given the limited amount of funds that states can make available, trying to award those funds to the schools with the greatest need, again, looking at the percent of the student body eligible for free or reduced price meals, and kind of that priority threshold varies from state to state, but it's a common theme of this kind of whether it's a threshold for a requirement to kick in or for priority for funding. It's something you see in a lot of these interventions. Universal free breakfast is something that is utilized by a small group of jurisdictions, but I think it's an important intervention, and it's this idea that breakfast is made available for all students regardless of their family income. So you don't have the free or the reduced price meal or full price meal. All students have access to breakfast. And again, these mandates are subject to thresholds set by the state, again, looking at student need as a percentage of student body for free or reduced price meals. And then kind of a related policy intervention is what is often referred to as the elimination of the reduced price category, which was probably better described as a merger of the reduced price meal category, where students have to pay 30 cents to get their breakfast. That category of students is merged with the students who are eligible for free meals, so that they don't have the same 30-cent copay they would need for breakfast. Again, there are exemptions that schools can apply for to kind of not participate in this merger of the programs. And one of the unusual ones is Maine exempts high schools from this requirement. And something that we'll kind of look at in a little bit is sometimes states make additional funding for the schools when they put these mandates in place. So, for example, in Maine, they cover the difference between the state government covers the difference in terms of reimbursement for the schools with this intervention. All right. And this is the last intervention we'll look at, but 16 jurisdictions provide additional per meal funding to schools to offset cost and encourage participation. So this is per meal reimbursement on top of what the federal government is providing. And within these jurisdictions, they really vary based on three main variables. First, what meals are going to qualify for these additional reimbursements? So in some jurisdictions, they provide the additional reimbursement for every breakfast that's served, whereas other jurisdictions will only apply this additional reimbursement to those free and reduced price breakfasts. Again, method of funding is a way that jurisdictions vary. Sometimes the reimbursement is automatic for the meals that are served at the schools, and in other jurisdictions, the schools need to apply for a grant to get that additional per meal reimbursement from the state government. And then obviously, the last kind of sub-variable on this is the amount that states reimburse schools for breakfast, this on top of the federal. And, the most common additional reimbursement rate that researchers found was 10 cents per breakfast, but some reimbursements are as low as 3 additional cents per breakfast served, and some are much higher. For example, in Minnesota, which has an additional layer of complexity, their additional reimbursement varies by grade level, but you'll see for the pre-kindergarten and kindergarten students, the additional reimbursement is quite high at $1.30 per breakfast served to these students. As I said, this is the final policy variable that we looked at in this research. Again, the research findings are available on the network's website, both in the issue brief and the 50-state survey. But I think it's really important to highlight this opportunity for public health to kind of look at this issue and figure out how we can address the breakfast gap, because it really is a missed opportunity to address the needs of food insecure children, both from a health and academic perspective, because of the implications that food insecurity has for both of those. And that is my last slide. If you have any questions or interests related to food policy, as an attorney here at the network, we do technical assistance requests on these issues. So if you have additional research interests in the area of school nutrition or broader nutrition programs like SNAP, please reach out to us. I do a lot of work in that area, so here's my contact information. And with that, I guess I will hand things back over to Charles.
Or you can hand them to me, Matt.
Or I will hand it to you, Carrie.
Thank you, Matt. Thank you so much for your talk, and to Erin and to Leah as well. We do have about 10 minutes for questions. We had a question come in for Erin that Erin actually answered in the chat, but then there was a follow-up. So the question was about school nurses addressing reproductive health and whether there was any pushback from parents or school boards. And Erin responded, yes, that school nurses do address reproductive health. State and district laws influence what that exactly means, and that there has been concern from parents and communities that does exist, but often not understanding what is or is not happening. So building relationships of trust is key. So Erin, the follow-up question is, do you have any suggestions on how best to have these services included in schools, those reproductive health services, and in particular, how to build that trust and explain the importance of these services to school boards?
Sure. I do have a few ideas. Like I say, I want to qualify it with the answer I gave before. This is, as whoever's asking probably knows, it's a very hot topic. It's a very sensitive topic because it oftentimes brings in and becomes more of a political issue than really an issue of what I think as physiology and part of nature and life. So being very sensitive of that, the approaches that seem to have worked best in the building the relationship of trust is really to start with just some discussions. I've known of several communities that were concerned, and to qualify, so I actually used to work when I was actually with an adolescent teen pregnancy group. So I'm sharing a lot from my own experience and for those around. But some of the things we learned was when just having discussions and setting it up to just have an open discussion. I remember one of my colleagues had a community and wanted to just have a discussion on it, and everyone came ready to fight. And that's not going to accomplish anything, because if everyone's just already dug their heels and think it's going to be about a discussion on abortion or a discussion on I don't know, birth control or whatever, then there's not going to be an ability to have a real dialogue. So starting with truly just trying to have some dialogue of I'm a data person, so I start with the numbers. Is there a specific concern? That you can discuss that concern, and in that you can start to build the relationships of trust and understanding with people so that the discussion can then lead to a discussion of what is the best thing to do in the schools about that, knowing what the laws are, knowing from a school board perspective who will be your advocates and those who are going to be your biggest challengers and why, and working one-on-one with both. It's a journey. It doesn't happen overnight by any means, but those are just a few things I can think off the top of my head that really seem to help in building those relationships. I can look into it more if you want to send me an email, and specifically if you have specific questions on it as well, but I would start there.
Great, thank you, Erin. Talia, we had a question come through the chat for you as well. They said, I'm aware of programs providing mindfulness training for students and teachers. Can you provide examples of interventions that provide both individual level interventions and broader built environment or other organizational systems, social determinants of health? Talia, are you still with us? I think you might be muted.
I am. I realized I was muted. I wanted to try to answer the question effectively, though, and when you asked it, is it about those types of programs and interventions relative to mindfulness and somatic practices being built in at the end? Was the question about those at the individual level and then how they're impacting social determinants of health, or is it writ large, other examples besides like restorative justice and what they're positing of mindfulness training? Do you know? I guess I can scroll on the side.
I don't know. I read it as it came in. So, Melissa, if you want to clarify in the chat box there, in the question box, that would be really helpful.
I mean, I'll take a stab relative to, I guess, bridging the gap between even mindfulness and restorative justice. You know, at the end of the day, childhood and adolescence, it's that formative developmental stage, right? We're laying the groundwork for well-being and health, but particular mental health in adulthood when we start to talk about mindfulness and somatic practices, somatic practices being things like yoga, tai chi, the body movement with forms of mindfulness. There's a substantial growing evidence for mindfulness-based approaches for use in schools, and in particular, it's about decreasing stressors in the acute stage of young people who are experiencing them with mental health difficulties, but also about helping create a range of responses and flourishing outside of it. And I think the same is true for restorative justice. How and where are we using individual level interventions? So, for example, a circle in a classroom that builds community that then has a broader structural organization, which is that that helps to scaffold against the possibility of a teacher just using exclusionary discipline and in-school suspension or out-of-school suspension to address a behavior that would have otherwise been resolved because they built better connection with a young person. This is particularly true when we start to think about implicit bias coming into play and how and where behaviors that are manifested by one group of students, for example, black girls, are in comparison to white girls as peers, and the expectations of femininity are different. And there's a whole body of literature that has tracked how teachers, for example, believe that adultification exists and that black girls are loudies or are hypersexualized as opposed to being in need of caring and nurturing and docile. And that's been looked at empirically. So I hope, at least in some ways, that starts to think about how, whether it be restorative justice or it be, for example, school-based programs around mindfulness, that really are about building that scaffolding at the beginning, both from a reactive standpoint, a young person's in a moment of stress, engaging in meditation, to the proactive in that by learning the skills of meditation, that you have a baseline when you don't need to intervene, or you're recognizing that things are starting to ratchet up for you, and that resilience then can be part of the totality of your experience of your life. And the same is true with restorative approaches, from restorative conversations all the way up to intensive Tier 3 interventions of conferences and circles. That's my stab. I hope.
Yeah, I mean, that was amazing, super interesting, and actually we did not get a clarification, but I think that was fantastic. So Matt, I think we have time for one question for you. You talked about ways to address food insecurity while school is in session. Or before school, but what's being done to help kids when school is not in session? So, for example, during summer break or school vacation.
Oh, gosh. I think there's a lot of interesting stuff going around to deal with this issue. You know, that there are a lot of kids who depend on school to get healthy meals, and when school's out, it creates a real challenge, additional pressures on the family to meet that need. And kind of the biggest program that tries to address that is through the USDA again, and it's the Summer Food Service Program. And essentially, it functions similar to the school lunch and school breakfast program in that the federal government provides reimbursements for meals served to children, but the organizations that can provide those meals and services to children is much broader under this program. So you can have schools serving meals during the summer, or local government agencies, state government agencies, nonprofits, and it doesn't have to be school-based. It can be at different locations throughout the community, really meeting the children where they are. Some jurisdictions have gotten really creative in how they deliver meals through this program. I know here in Maryland, one of our counties takes school buses and uses them to deliver meals at different locations throughout the community. And this can be really helpful in communities where it may be more rural and the distance to the school is more of a challenge. I know in New York City they've been using food trucks so that kids can, go and get food at a summer food truck. So it's a really important, program through the USDA. There have been some pilot grants where states have gotten additional funds to supplement the SNAP benefits of families during the summer. So using these kind of pilot federal funds so that kind of the additional cost of feeding their children during the summer you have some additional SNAP funds to do that when you've been relying on the school during the school year. And I'm very proud of my state. Maryland passed a piece of legislation this year that the state is providing additional funding to SNAP beneficiaries who have school-age children during the summer. So they get additional funding during the summer, but they also looked at providing additional SNAP funding to these families during the winter break, realizing that, the family needs are going to be important during that time period where the students are away from kind of the traditional lunch and breakfast opportunities of the school. But, there's a lot that's going on with government, but, government, it really works well with nonprofits in this area. So I know there are a lot of nonprofits that are working in this area to help in terms of serving meals. And you have great kind of like backpack programs where kids are, sent home with additional food to help meet the needs when they're not in school. Kind of on some of the for example, over the weekend you have these interesting backpack programs that are doing a lot of good out in the community. So I think there's a lot going on in this area, but it's definitely a challenge that I think we need some additional kind of public health attention to these kind of gaps in food resources for children.
Awesome. Thank you, Matt. So I want to be mindful of everyone's time. Mindful, see what I did there? And so with that, we're going to close the webinar for today. There was another question that came in. It was from Matt, so I'll make sure that I pass this along to Matt. And so you will get an answer via email. And so thank you again on behalf of the Network for Public Health Law for attending this webinar. A recording will be available on the website, and you can visit that our website right there, right in front of you, in order to see the playback of this webinar. Thank you again for joining us, and have an excellent evening.